Hey everyone, Dr. Sorin here, and I just want to explain some anatomy as to what are epidurals and how do they work and what are the indications. So if your doctor recommended an epidural, stay tuned. I'm going to help explain what that is and how it works. So let's talk about this. Epidurals are used oftentimes for lower back pain. And what are some of the stats? Now, I got these from the Medicare LCD. So this is the Medicare guidelines for injections. Low back pain is highly prevalent, with reports of about 50 to 84% of adults experiencing back at some point. So that's pretty wild to me. Half to three quarters of people are going to have a back pain at some point in their life. And globally, lower back pain is the highest cause of disability. So the biggest reason why people can no longer work is back pain. And even a more surprising statistic is 28% of men and 31% of women over the age of 18 have had back pain in the last 3 months. So roughly almost 1/3 of people have had some sort of back pain. And so many people can relate to this. So there's a lot of controversy as to how to treat back pain and all the different options, but I just want to specifically talk a little bit about these spine injections. So part of what's important to understand is this is called the spinal canal is surrounded by something called the dura mater. That's Latin for the tough mother. This tough membrane, the word durable and all that comes from it. So this tough, durable membrane protects the spinal cord. So an epidural means you're putting something, epi means on top of, like the epidermis. So on top of the dermis, right? Your skin. So an epidural goes on top of the dural membrane. And here on this image, you can see the spinal cord and then the exiting foramen. Foramen is a term for a hole, an opening. So this whole opening is foramen, that where the nerves exit from the spinal cord. So over here on the left, you see another similar image. So there's a spinal cord in the middle, and there's the exiting nerves right there. So what does an epidural steroid injection do? You drive a needle in, and you're putting it right here just on top of the dura mater, the tough mother. So the spinal cord is down here. You've got this tough membrane protecting it, and now you are putting the steroid and local anesthetic or just saline out here. And so now you can see if somebody's got a bad disc bulge over here, and now all of a sudden you're putting all this fluid on this side, you can see how that would cause some pressure. So sometimes when people have an epidural, they can feel an increase in their pain temporarily or an increase in pressure. Thankfully, that dissipates fairly quickly, but that just helps you visualize and understanding what an epidural, where it's going and what it's doing and how it functions. And just real quick, as small aside, epidurals oftentimes when we do them for pain will have steroid in them, and that steroid helps reduce any inflammation around these nerve roots. That's how they function. And here's some pictures. Again, there are 2 ways of approaching it, 3 ways, which we're going to cover in a second, but you can see the needle here in the epidural space and the contrast medicine spreading. So this is the way you would want to see it spreading. And from the side, you can see it layering out there. So this is what's called an interlaminar. And then this is a transforaminal where you're going in from the side right next to the nerve, and you can see that contrast spreading there. So there's 3 different approaches you can use for an epidural steroid injection. The first one is the interlaminar, which means going between the lamina. And then the second one is transforaminal, which means you're going through the foramen. Remember, a foramen means an opening, so you're going through that foramen. And then the last one is called a caudal, where you go through the sacral hiatus down here. So interlaminar, this back part of the spinous process here, is called the lamina. And so interlaminar means you're going between the lamina. And then transforaminal, trans means through. So through the foramen means you're going right next to the nerve through the foramen. So colloquially, I call these interlaminar. It's a broad spread of medicine. It's going to go all along the back of the spinal cord canal. And then the transforaminal is more specific. So I tell people that's more like a sniper. You're going to very specifically treat one nerve root. And then the last one is called a caudal, where you go through the sacral hiatus here and you drive the needle forward. And a common reason to use that is if somebody's had a lot of surgery and the anatomy has changed or you just can't get in, you can approach it from below and not have to deal with the surgical hardware there. Let's take a look at some pictures here. This is an interlaminar injection. Again, you're going between the lamina there at C7T1. And so you can see you're going into the epidural space there, placing the needle. So a transforaminal means you're coming in from the side through the foramen. So again, this is what I call the sniper approach. And you can see it going up along the nerve and up into the epidural space there. So you can see nice flow of the medicine. And again, you're specifically treating one nerve root, whereas you look at the interlaminar, you're broadly placing the medicine here in the epidural space, so it goes over a broader space. You can see it here. See how it's going 2 levels versus a transforaminal is really focusing on one side and one level. So now we talked about the transforaminal, and lastly, I want to talk about the caudal, which is where you place the medicine through the sacral hiatus here and going up towards the cell 5S1 level. And you can see nice spread of the medicine there. And there you can see nice spread on lateral view of the caudal injection. One other question that comes up is in the caudal, why not just do an interlaminar and just go up higher? Why not just go here? One thing that happens, if you remember this slide here, so when somebody's had surgery, sometimes these tissues can all get fused together and make it more difficult for the doctor performing the procedure to miss that epidural space and go right through into the spinal fluid. So if you go under here, it's where all the spinal fluid is. And if that happens, you get something called a wet tap, which means you'll see spinal fluid leaking out, and that fluid can continue to leak once you pull the needle out. And it can cause a headache, what's called a post-dural puncture headache, and that's no fun, so you really want to avoid that. Anatomically, if somebody's had a lot of surgery, it's best to try and avoid that area. It can be done carefully, gingerly, but again, you increase that risk of getting a wet tap. The most common indications, again, this is Medicare guidelines, is number 1, lumbar, cervical, or thoracic radiculopathy or radicular pain. So radiculopathy refers to nerve root pain. So pain stemming from these nerve roots that can basically go down your leg, or if it's in your neck, and go down your arm. So that is the most common indication for these injections. There's some others down there, but generally you want to think of it as treating nerve root pain coming from where the nerves are coming out of the spinal canal. Number 2, you can get post-laminectomy syndrome. So if somebody's had multiple surgeries, continues to have a lot of pain, that can help reduce the inflammation in the area. And then lastly, another indication can be for acute herpes zoster associated with pain. So if somebody's got shingles, herpes zoster infection, you can do an injection to help. So hopefully this helps explain some of the reasons why your doctor may choose to recommend an injection. And if you have any further questions, write them in below, and maybe we'll do another video answering some of the other things associated with this. Thanks for watching. Have a great day.